So we're going to just basically have a conversation here for the podcast for Startup DPC, and we're just going to kind of record and see where things go. Dr. Paul, I spoke too much, man. You got
No, it's good, man. It's awesome. So thanks for tuning in, everybody. We're recording here on my laptop. And for everybody watching here, this is Startup DPC. This is our Startup DPC show. And this is going to be probably our 7th episode of doing this. They're all on startupdpc.com. And they're also on our YouTube channel, youtube.com/startupdpc. And really, it gets down to finding doctors who want to start a direct primary care practice, or the doctors who are in the first year or two of starting their DPC practices and growing their DPC practices so that they can be the best doctors that they can be in this model. Because there's a ton of challenges in our current healthcare ecosystem. I'm sure you're facing it every day. So I kind of want to turn this back to you. For everybody watching here, this is Rami Webby. He's a second-year resident at UMass in Boston, and he's, thinking really critically about what to do next in his journey. And so, tell me about your current situation. You had mentioned you're at a FQHC clinic.
To start, I'm at an incredible program. UMass is probably one of the best programs in the whole country for primary care. It's number 1 in the entire New England area. Our leadership at that program is like second to none, and they put a lot of effort into producing great primary care doctors. So I'm very fortunate to have been able to transfer to this program. I actually did my first year at another program, and in Pennsylvania, right? In Pennsylvania, yeah.
Yep.
Yeah, so I've had a very interesting journey so far, but I faced a pretty big dilemma when I was a medical student, and kind of seeing the way doctors were practicing medicine as a whole, not just in primary care. And it was a little disheartening to start off because, my vision for medicine starting off was, I saw my uncle as an entrepreneur, as a dentist, practicing within his own community, having a little bit more control of his practice and, caring for his community. And I saw that was less and less the case in medicine because primary cares were getting bought out by big hospital systems. And there's little room for the creativity and the innovation that comes with owning your own practice. And for me, that's always been a big motivating factor, is like having that office, having that fish tank in the office, having a nice couch, being able to direct your team and having like a core leadership within your practice. And for me, that's what inspires me and what drives me. And as a medical student, I thought, well, are there any docs that are still doing this? And it got me to start to think and search online to find out, is there a way to still do this in this current market, in this current system? And lo and behold, I did come across direct primary care. At first, though, I will say I came across concierge medicine, which was, to me, still held a little bit of a stigma because, you're basically only treating, when you think about concierge, you think about the people in Beverly Hills who can pay for a private doctor to visit them at home. But that's not really the case with direct primary care. And Dr. Paul is a perfect example of that because he's working with the community here in Southwest Detroit and bringing incredible value and service to these people here at a very affordable rate. So it shows that this model works not only for the rich, but for the middle class and even for the poor, depending on how you formulate your practice. So this was my journey initially starting off. I came across Dr. Paul through a friend actually who had interviewed him on another podcast. I heard his story. I heard about how he got started, and I was just like instantly drawn to that idea. And I reached out to him, and he met with me, and we talked more on my podcast. And that was the beginning of a good friendship with my man Paul here.
Thank you. Thanks for saying so.
Yeah, and he's become a mentor for me because I've learned the ins and outs of starting a direct primary care from him, from the podcasts we've recorded together, and I want to pass that on to other students and other residents, and Paul wants to do the same as well.
And that's a huge driver for me, is not only taking care of patients in our practice here in Detroit, but also helping doctors to take care of their patients in their communities on their own terms and deliver really high quality, excellent primary care services.
Yep. Yeah. So it's really cool to see the way that this model has kind of like grown for Paul, because it gives me inspiration, because I know that, you know, there's a reason this is working. There's a reason that people are seeking different models of healthcare, because the traditional model is not working. You know, people are paying a lot of money for insurance every month. They are having to wait hours upon hours to see their doctors in waiting rooms filled with sick people. And they're not getting the quality service that people are expecting. And it's partly, I would say, you know, maybe in the private care model, it still wasn't the case that people were getting excellent care, but it was probably better care than what I think people are getting in the traditional insurance-based system. And so Paul has currently, what's your panel, like 500 patients right now?
Well, mine is about 460, and then Dr. Raquel is our second physician in our practice, and she has about 180 patients.
Okay. So for those of you, like, to put this into perspective, the average primary care physician in, you know, an insurance-based practice will have about 2,000 people within their panel. And so what that means...
2,400.
2,400. So that,
Yeah.
So what does that mean in terms of how much patients you're going to see in a day?
Yeah, you're going to see 1% of your panel each day on average. So that's going to work out to 24 patient visits each day. And if you break that out by hour, that's about 3 patients an hour.
Yeah.
And then if you have a clunky EMR where you're spending more than half your time charting and less than half the time your time seeing patients, you're going to see your patient for 8 to 9 minutes or 10 minutes and then have 10 or 12 minutes to chart. And then, by the way, doctors are spending 86 minutes every night doing their notes. And sometimes we jokingly call it pajama notes, but it's really sad, because you put the kids to bed, you pour yourself a glass of wine, you finish your clinical documentation, and it takes over an hour to do that. So it's a reality in primary care right now, and that's why a lot of doctors are leaving the fee-for-service system for a direct primary care practice like this.
And so how does that translate now into your practice? Like, with the current panel that you have, how many patients are you seeing in a day, and like how much time are you spending with a patient?
Sure.
What's the difference between the way you're practicing versus, you know, your colleague that's in an employed healthcare practice right now?
It's a great question. So because I have around 500 patients, you know, I've got 460 right now, I see about 1 to 2% of my panel each day. We are in Southwest Detroit. This is a higher needs community. We often have people walking in and saying, you know, I haven't seen a doctor in 5, 10, 15, 20 years. So it's going to take a lot more time and a little bit more intensity to help those patients optimize their health. So, you know, 1 to 2% of my panel each day. So I'm seeing about 4 to 8 patients a day. On a really busy day, I'll see 12 patients. And so that works out to 30 minutes per patient. And I really get to look them in the eye, take care of them. I often have a student who's rotating with me. Oftentimes they write the notes, so I really can just focus in on taking care of my patient. When I do need to write notes, I'll have my computer, I'll take a little notes. I'll always ask, you know, is it okay if I take some notes while we talk?
Yeah.
But I always leave myself 5 minutes between my next patient so I can complete the note. And it really only takes me 5 minutes because it's a SOAP note. I'm just free texting what they tell me.
Yeah. Whereas, like, you know, some of your colleagues might be seeing 25 to 30 patients in a day, and that's
Sometimes
actually written
35.
and that's written in the contract too, when you're starting with another, like, you know, when you're taking on a new role as a physician with a company, you know, you have a certain criteria of benchmarks you need to meet to fulfill your contract. And so, like, for me, it's mind-boggling that you'd be expected to see 35 patients in a day and expect people to get quality care. It's just, that doesn't make any sense. There's no way that you can see that many patients in a day and still, you know, and like actually deliver real good care. You can see a patient and address one problem maybe, which is what a lot of people do.
And that's the thing. It's like sometimes somebody comes in with a list and the doctor might say, hey, we only have time for 1 or 2 of these things. And then oftentimes primary care doctors don't have enough time to use all the tools in their toolbox, and they end up referring everything. So if there's a musculoskeletal complaint, they'll send somebody to the orthopedist, or if somebody's saying, I feel like I'm having some mental issues, they'll send them to the psychiatrist. And then it takes 4, 6, 8, 12 weeks for that patient to get in to the specialist, so it's delaying their care. Meanwhile, they have 6 other things on their list they want to address. So really in this model, you have enough time to fully address all those concerns of your patients.
Right. And, a lot of questions, like whenever I kind of speak about this model to other people or like tell people about it, their main concern is like, oh, but wait, patients don't have insurance. They don't, how do they see a specialist? What happens if they get really sick and go to the ER? And these are all things that, Paul's obviously been finding ways around over the last couple of years, but they exist and there are other options for patients. And I think for people that are curious, what's your answer to that?
Well, the first part is that we just have more time. So
Yeah.
if somebody's coming in with depression, we can do a Beck's inventory in the office and figure out where they're at. I have the medications in the office. We can start them on something like sertraline for 3 cents a pill, follow up with them in a month and make sure they're on track, send them some text messages in between time. How's it going with the med? That sort of thing. You can be more intuitive in your care when you have more time. Then, I have more time to look things up and read about things. So if somebody's coming at me with a unique presentation or a different diagnosis that I don't see very often, I have the time to go on UpToDate or talk to some of my other colleagues. I wouldn't shadow a specialist just to learn more about that specialty. Because I took a half day away from my practice because I could to just learn more. Then the third thing I use is Rubicon. Rubicon MD is a e-consult platform, and I can take the history of my patient, take out any identifying factors, and send it to a specialist on that platform. If it's a cardiology consult, I'll include the EKG and the echo findings, the meds they're taking, all that kind of stuff, family history of heart attacks and strokes. And then I can get a robust answer from a specialist in 4 to 12 hours. And that's a real amazing part of it.
And is this for any specialist?
Any specialist. There's like 200 listed specialists on the Rubicon platform.
That's amazing. Is this a monthly service?
Yeah, I pay a monthly subscription to use it, and it ends up costing my patients nothing because it's baked into the membership cost.
See, this is what is so fascinating because, how long has this system been around? Has it been around for a while?
Direct primary care or Rubicon?
The Rubicon.
I think they've been operating for 2 to 3 years.
2 to 3 years. See, this is the thing, all this technology is coming out, new startups all the time, ways to improve our health. And I think that this is just the beginning of the real kind of growth and empowerment that doctors are going to have at their fingertips.
Oh yeah, and there's already apps where you can take care of a dermatological lesion and send it off to a dermatologist and have a second opinion. There's already a handheld ultrasound probe called the Butterfly IQ.
Yep.
It's $2,000, plus you have a subscription on that. But if you really wanted to do point of care ultrasound and you wanted to get proficient, you could do a weekend course or shadow a doctor in the emergency department who's proficient and start using that tool in your office. These are added benefits that you can give your patients. You can be a better doctor, have more time, address more concerns, prevent. A lot of times we send patients to the ER because we think they might have appendicitis.
Right.
You could save somebody $2,000 just by having an ultrasound probe in the office. So these are the things where you can be really innovative in your practice and play to your strengths as a physician, really save people money and deliver better care.
True. Another really interesting, talking about the ER, the emergency room visits, is a lot of people think, if I already have insurance, why am I going to pay for another membership service? Or why am I going to, if I already have insurance, why would I go outside of the traditional healthcare system and pay for a membership based service? And there's, I think what a big part of, the solution finding for direct primary care is going to be kind of like that patient education, the education of people every day that, this model works because it's going to, save you time. And it's also, if you frame it, if you do it in the right way, it can save you money every month as you're getting better care because you can restructure your insurance plan. A lot of people pay for really expensive insurances when, for me, for example, I'm paying something like $200 a month right now through maybe more through my residency insurance plan. And that comes out of our paychecks. but there are ways to restructure your insurance so you can have like a high deductible kind of insurance or
high deductible, low premium plan.
right. So like instead of paying $200 a month, you can have $100 a month insurance. If you're a relatively young, healthy person, I think that's reasonable. Whereas like, you know, you're going to see your primary care and you're going to get things followed up on that way.
The crazy thing is your employer is probably spending $400 a month even before it gets to you for your health insurance. So that's $600 a month in total. And that comes out to what, $8,000 a year, you know, somewhere in that ballpark, $7,000 to $8,000 a year. When, you know, and this is probably a conversation for another time.
Yeah.
But when
I was about to go down a huge rabbit hole right now as you were saying this, because there is a huge market for this, where a huge, you know, market to save a lot of money for not only for patients but for employers as well, because there's this huge outpouring of money that's going. Okay. There's this huge like outpouring of money that's kind of like, just kind of like almost being wasted in a way.
Yeah, totally. You wasted the middlemen. There's all these insurance-based markups, and you're paying for the middlemen who coordinate these insurance plans, the insurance brokers, etc. Hey, so there was just a break there because Rami took a phone call on his phone. But for all of you watching, this is Dr. Rami Webby. He's a really big influencer on Instagram, especially among medical students, residents, and doctors. And so, what's your Instagram handle, man?
It's at drrami.do, Rami, R-A-M-I.do.
Yeah, Dr. Rami. And then he also has a podcast, the Beyond Med podcast. So we're doing we're doing a little cross promotion here, if you will.
Yeah.
But yeah, that's a huge thing. Wouldn't you rather, as an employee, have an extra $7,000 or $8,000 a year, and your employer would probably be relieved of it too, because they could pay you real wages, higher wages, and not waste so much money on the middlemen of the health insurance game.
Not only that, like what's interesting about it for me is that, like, when as an employer, you want to offer quality service to your employees, right? You know, I think of a company like over here in Quicken Loans in downtown Detroit. You want to offer exceptional services from your company that are going to make your employees want to be part of your company, right?
Right.
And so when like these things, like this model, you can approach these companies and say, hey, we're offering this service to your employees. They're going to have they're going to have, you know, personalized care. They're going to have their own primary care doctor that is committed to them. You know, your employees, when they get sick, they're going to be able to call us directly and get an appointment the same day. They're going to be able to come in and get their labs done and everything done very conveniently. And then on top of that, hey, we're going to save you a bunch of money too. And so like there's this win-win-win situation, like for the patient, the employer, and the physician, that is really, really obvious to me, and also really exciting, because it's just, you know, you're taking out the middleman, which is just a huge waste. And you're you know, a lot of people are winning in this situation.
We got a question over here. Might be a dumb question.
Oh, what's up, Leah? How do you think?
We're fielding questions from Instagram here.
Yeah. So how do you think this would affect the unhealthier people's premiums? There's the thought that healthy people end up covering some of the costs of the sicker ones, and that's actually a really good point, because there is some truth to that, which is kind of like, at least when I think of an insurance based, when I think of an insurance provider, a lot of insurance providers are making money off of the, you know, from the healthy people. You know, you have a very large pool of healthy people who are essentially going to be making up for the costs of unhealthy people, which is interesting, because if you think about the way what would happen if direct primary care were to like go on and be really successful, where you'd have a lot of healthy people pulling out of the traditional healthcare system, it probably would cause a big problem for insurance companies, because then they're stuck with people who can only go through the traditional system, and they're left with essentially a pool of very sick patients, which could be that, like, that's a whole nother.
Well, on the other side of that, if you are less healthy, if you do have a lot of chronic conditions, it behooves you to seek out a direct primary care doctor
And there's
who's
also
going to
that-
have more time to actually address all of your concerns. And so I've had that situation where I've got somebody who has high blood pressure, diabetes, COPD, and they just felt like their doctor was kicking the can down the road and didn't have enough time to address all the concerns. So they're seeing us because we actually can set aside an hour for them
Yeah.
and be comprehensive in our approach. And then we're saving their insurance company a ton of money,
Right.
because we're addressing all of their concerns and preventing them from going to the hospital, going to the emergency department, using an urgent care that their insurance company would have to cover.
Right.
So, it's like, half in one, has half a dozen in one, six in the other.
And then this also brings up another interesting topic, because so like you just mentioned, with insurance is saving, because you're taking better care of patients, especially elderly with chronic problems, and saving trips to the emergency department and to the having inpatient hospital admissions. You end up saving the overall healthcare system a ton of money. I don't know if there's any data on this right now or any research on it, but it only makes sense that if you're taking care of people with chronic conditions better, you're going to have less of these admissions that really could have been easily prevented
or treated by a good primary care physician. Like, the joke I make is that, the urgent care system is a symptom of a failed primary care system. Because if your doctor had enough time to see you when you cut your finger or when you have bronchitis, you wouldn't even have to go to an urgent care. Now, primary care doctors are so overbooked, they have too many patients, there's no way to fit you in that day. You have to go to an urgent care to get acute care needs met. Or the emergency department. And so you're going in the hour of your greatest need to a doctor you've never met before. Or even like a PA or an NP who's staffing that urgent care or emergency department.
Right.
So that's where this model makes a lot of sense. We have the continuity of care, and then when people get sick, we see them. So like, for example, last week on Monday, somebody cut their finger at 5 o'clock. They had like a V-shaped gash. It's on my Instagram at Plum Health DPC. You can see the photos. They had like a skin flap. We sewed it up, 10 minutes after they called us. They live in the neighborhood. They called us. They came over. We sewed it up. Saved them a $2,000 trip to the emergency department.
Oh yeah, like that.
Easily. Or $250 at the urgent care. And it's free because they're a member.
Yeah, and that's one of the things that I love about this model of direct primary care, because it allows you to do these things. It makes you want to, there's also like this ownership aspect. These are your patients, they're not your hospital's patients. They're your patients. You take full ownership. Like, you will go out of your way to go do these kind of things. Whereas if you get a phone call in the middle of the night, it's just, it's a different frame of reference, I think.
Yeah, it's a different mentality. I say you take radical responsibility of your patients, because you are their connection to the healthcare system, and they really trust you with their concerns.
Yeah.
I think we got another question.
Yeah. How do you create more time for patients? Are you seeing less patients overall compared to someone not in direct primary care?
Yeah, for sure. So, a typical family doc has 2,400 patients, and a typical direct primary care doctor has 500 patients. So because we have 5 times fewer patients, we can spend an hour with them during a visit, or typically 30 minutes for follow-up, 1 hour for initial appointments. If I know somebody's really complicated, I'll set aside an hour for them.
And the reason, Aaliyah, back to your question, the reason that Paul is able to have a much smaller pool is because, number one, financially it works out, the model works out where you can have a much smaller pool and still kind of create the same kind of compensation that you would get in a larger pool in a hospital system.
Right.
Because you have much lower overhead in this system, and you have the monthly membership is kind of creating your salary in a sense.
Exactly. Yeah, because people are paying, $10 a month for kids, $50 a month starting for adults. We have that recurring revenue. And then any additional tests we do in our office or additional meds, we're billing at cost. And so, we have a pretty stable, expectable revenue. It's like a predictable revenue is the phrase I'm looking for. And that's because of the membership.
Yeah. Aaliyah, like I'm in the exact same ship as you right now, and I totally get it. And so got a question from my Instagram, and it's like, this is another resident doctor who's in the same year as me, and we all feel the pressure. We're seeing 18 patients in a day if you have a full day set up for you, and we do what we can for our patients, and we go above and beyond to try and do the right things for our patients, and it's exhausting for us to do that on a daily basis because we don't sometimes resources are short. So the EMR is not the best, and then there's a lot of obstacles that we have to navigate through daily, and it's something that we understand that comes with part of the job, part of the training, that's part of the medical system right now. But what I also keep in mind is it doesn't have to be that way afterwards. Once you're done with the training, if we can make it through the traditional system, starting this practice and practicing in this way is just going to seem like heavenly, because like we know what it's like on the other side in a sense. Yeah. Not to say that there isn't a lot of hard work that goes into starting this, and the patience and having to really have the right vision, but it's
a different skill set, and like if you enjoy that skill set, then this style of practice can be really enjoyable. Right. So for me, I really enjoy the branding, the marketing, the speaking at events, speaking at conferences, meeting people at the local library or the local high school and talking about what we do, or going out to the local residencies and educating other resident physicians or medical students about what we're doing. So like if you enjoy those facets, if you like creating like your own logo and writing about your practice, maintaining a blog, having a YouTube channel, all this kind of stuff becomes natural and becomes really fun, frankly.
Yeah, and like a lot of us have that creative side, especially a lot of the people on social media, like Aaliyah, who's already does really well with her blog and her social media, like people like that, like you're like that, having that marketing ability and having that presence and having that that know-how that already comes naturally from doing this for so long, that it really just works to your benefit to be able to do that. But
I will say, like, direct primary care is a lot about marketing and communicating your value to the community and teaching people about what you do and why it's beneficial for them, their family, and their businesses. And so if you're really in tune with Facebook and Instagram and LinkedIn and YouTube, among others, like we could go on TikTok, Snapchat, whatever. If those are intuitive platforms for you to communicate with people, then you're going to have a lot easier time starting your practice. Yeah. Right now, it's like, I'm not too old. I'm 32.
You're old, man.
Yeah, but I'm old for Snapchat. I'm old for TikTok. But
dude, you're 32?
Yeah.
What the hell?
Yeah. But, it's like
fastball.
It's like, the younger doctors, all this stuff is going to be more and more intuitive, and then it's going to make more and more sense for you to go out on your own and build your own personal and professional brand. And that's something I talk about a lot when I speak at conferences, because the older doctors in the movement who are like 40, 50, this isn't second nature, so it's a lot of work for them. And for you, it might be more intuitive. I'm looking at the Instagram screen when I'm saying this.
Yeah. So we had another question. It was, do you do a lot of procedures? Some things I'm training for, but I worry the equipment would be too expensive if you were to have on your own. Examples like colposcopies.
Sure. Dude, if you love doing colposcopies, I'm sure you could buy a colposcope for $2,000. Just like we bought an EKG machine for $1,700. It's kind of like a must-have. We have a PFT machine for $700.
Yeah.
You can get a small business loan when you start your practice, buy that equipment that you need, hopefully get a low interest rate, and it's going to pay for itself over time. And you could, if you really want to focus on something, you could really dive in on that. Right. So do you really want to focus on women's health? You could invest in, having a colposcope. We just invested in some Botox for our patients because we had a lot of requests, and something Dr. Raquel's passionate about. She really wants to engage in Botox care. So, it's good for headaches. It's good for wrinkles. It's, good for a few things that are going to be beneficial for a patient population.
Yeah.
So if you have a patient population that's a lot of young women, a lot of HPV diagnoses, it might be a really good thing to do.
Yeah.
I do a lot of toenail removals. Those are virtually free. It's like $15 for a kit to remove a toenail. I do laceration repairs, again, $15 for the kit, $7, $10 for the suture material. I do a lot of abscesses, incision and drainage. That's virtually free. It's like 10 cents for an 11 blade.
Right.
And then I'll do a lot of biopsies. Derma blade is a few cents for one of those flexible blades that you can remove a lesion. And then we charge our patient the $70 for the pathology fee. So the patient's picking up the bill for the pathology fee. We don't pay them to remove the lesion.
Yeah, so there is that aspect of like direct primary care also that I really like, in terms of like you are a business owner, and you are free to kind of cultivate and brand your practice in whatever way you want. And like for me, I think like with my direct primary care, like I'm gonna take more of like an integrative, holistic approach to my kind of practice, and maybe like a kind of like I'd like to focus on like the new innovations, like in terms of like health, and like especially like like things like heart rate monitoring, CGM, continuous glucose monitoring, all these new innovations that like really focus on healthcare, not like so much as sick care. And that's for me my vision. And so like I'm going to cultivate my practice in that way. And then if you're focused on women's health, you can also brand yourself and focus your practice in that sense as well. And like that's all part of the creativity, and part of that's like for me that's what I think is the fun part that really keeps us engaged in our work and makes it exciting, makes us excited to go into work every day.
Yeah. So everybody, Dr. Rami Webby, second-year resident from UMass in Boston, visiting Detroit to come check out our practice and hang here. Any closing thoughts you have, Dr. Webby?
No, but yeah, thank you guys for listening, and thank you for Paul for having me on the show, and for for all the teaching and for all the future mentorship that I'm going to hold you to.
Yeah, of course, man. Happy to do it. Yeah, and everybody watching, this is a Startup DPC show. You can find us on YouTube. You can find us on startupdpc.com. And we really take a deep dive into branding, marketing, how to write a business plan, how to find the perfect space for your direct primary care practice, how to build out an office. We're sitting here in our brand new office, 1,700 square feet, and really how to attract patients to your practice. We mentioned branding and marketing, but if you really want to take a deep dive, we have some courses on our website at startupdpc.com. So thank you so much for watching, and have a wonderful day.